So, good evening, everyone, and thank you all for joining right on time. So, we are here today for the first session of our CaReMe Pro 2025 series of webinars. And with me today, we have Dr. Gagan Priya. She's a renowned endocrinologist from Punjab, and I'll just brief you through the entire how we're going to go through the entire session, and then we'll start with the case discussion. You know, right. So, good evening, everyone, and so what exactly is CaReMe Pro, and what are we trying to do? So, this is one of the ideas behind the entire series of webinars is that we often tend to have a very narrow vision of our patients. We tend to see patients over a shorter span of time, generally, over the next 3 months or 6 months. It's like how is it going to play out in the upcoming next consultation. But then, remember, patients are living, breathing people, right? They want to, they want the full picture. They want to see how things are going to play out over a long period of time. How it plays out over a series of decades. So the idea is really to show you the entire picture, to show you how the patient's journey goes, through the long series of the entire thing. So that's the whole idea of this series of sessions. So we're going to have 4 sessions, and each of this has a flow, has a system. So what we're having right now is the webinar. So you can, we're viewing this webinar. We'll read out the patient story. So we'll tell you the patient's journey through this webinar, and it will be an interactive session. So we will discuss the series of events with our expert today, Dr. Gagan Priya. And before the webinar, so before the next webinar, you can we'll upload the case as well. So today also we have uploaded the case, so you can go through the case. It's a detailed discussion. What we are trying to do is to try to make it like the Harvard Business Review, right? So Harvard Business Review is a very nice little story of the case, and it has a lot of academic value also. So we're trying to integrate from a Harvard Business Review kind of way. So you can download the case before the webinar. You can go through that. We'll be discussing the case in detail with Dr. Gagan Priya, and it will be an interactive participation. So you will get a chance to answer some of the poll questions. We'll see how it goes, and also we'll allow you to interact with our expert. So you can put in your questions in the chat, as well as we'll discuss some of these points in the end as well. So this is how we are going to go through the entire webinar flow. So this is the schedule. So this is the 4 webinar series. The first one is today's, and then we're going to have a discussion with a cardiologist, and then a nephrologist in the upcoming weeks, and with a hepatologist in the last session. So we are going to see the whole spectrum of how SGLT2 plays out and how it really plays out over a long period of time. So that's the whole idea. Now, if you've been through any of our webinar before, we have something we call it the Technochronology way. So any learning has 3 stages. So you have the Shravan stage, where you learn through the case material, attend the webinar. This is what you're doing right now, is Shravan. And then you also have the Manan. So on the technochronology.com platform, if you're not done so, I suggest that you sign up. If you're signed up for this webinar, you'll get, at the end of the webinar, you'll get an email with the how you'll sign up, and I'll also put the link in the description. And we'll have the the Manan has certain quizzes, so you can go through some of the questions, some multiple choice questions, which will be useful. And then we have the Nidiasan, where you reflect on what you learned. It's very important to go through what you're learning, to reflect on your learning, and that's the Nidiasan stage that you'll be going through in the last sessions. And to access the course material, this is the link. So it's on technochronology.com. I'll just put the link in a second on the chat as well, right? So this is the link. So there's easy access to the link, and you can scan this QR code also. Here you will get all the case, the reading material, the additional some additional notes, etc. So without much ado, let's start. And today we have with us Dr. Gagan Priya. So ma'am is like a mentor to me. I remember, the first time I interacted with her was when I was a student and I was part of TISA, which is the Young Scholar Award organized by ESI. And ma'am was the judge, right? So, and that was the first time I had a chance to interact with her. And I still remember the questions she asked. It was the last case was a case of Cushing's patient. And the questions, I still remember those questions. So, thank you for being there. Ma'am is a highly reputed endocrinologist and diabetologist from Mohali in Punjab. She is practicing at Fortis in Mohali. And she started a career with the Government Medical College Patiala, where she completed her MBBS and then went on to pursue her internal medicine at the SMS Medical College Jaipur. And after that, with a brief stint as a medical officer at Fortis Mohali, she was selected for DM endocrinology at nothing less than AIIMS New Delhi. So she's an alumni of AIIMS. During her training in endocrinology at the AIIMS, she gained a vast experience in management of difficult and challenging cases. She participated in a lot of national and international conferences. But then let me tell you, she's not stopped since then. She continues to be the bedrock of the Endocrine Society of India. She's currently an executive member of the Endocrine Society of India as well. She's been working as a consultant endocrinologist in Mohali since 2007. And she's one of the most reputed endocrinologists in the Tri-City area of Mohali, Chandigarh. And she has a keen interest in PCOS, in pediatric endocrinology, in type 1 diabetes, and of course, type 2 diabetes, which is the bread and butter of all of us. She's a founder of Flame, and she's also the founder president of WeCare, both, women endocrine associations. And she's also the associate editor of Chronicles of Diabetes Research and Practice and Diabetes of India. And she's a SCOPE certified in obesity. So she's an expert in obesity, and she's keenly interested in obesity also. And the area of obesity is now heating up with the lot of new medications in this sphere. And what's the best part about her is that she's known for her patient-centric approach. So as you'll see, the right person for this webinar, she's the right person for this webinar because, the way she deals with a patient, I think that's the key which we are going to, see in action. So this is Dr. Gagan Priya. And before we start the webinar, ma'am, any words before we begin?
Yeah, thank you, Om, for inviting me. I think it's a lovely time that we'll have here. A lot of interaction. I'm expecting some very wise words. I'll tell you all that Om was the winner of that TISA award, and we really felt him like anything.
Right. So yeah, thank you. So I think my voice is a little dampened. I'll just start that. Okay. So just give me 1 second to share my screen again. So let's begin with the first case and with the case today. And like I said, this is going to be an interactive webinar. So please feel free to, put in your questions in the chat. And also we'll be having some polls so you can interact with us in the poll also. Yeah, please my mic input. Yeah. Okay, so yeah, Dr. Samir, is my screen visible?
Yes, now it is visible well.
Yeah, the screen is visible.
Visible, sir.
Okay, thank you. So let's take the first case we are having this week, and that's a study of a tale of two treatments. So what we're going to do is, in this case, we are going to compare the journey of two patients. Both of them presented in a similar manner, but one of them was started on the standard of care, which is actually still metformin as the first therapy. And the second one was started on metformin plus SGLT2. So we'll see how their journey panned out and how things moved over a series of a longer period of time. So let's begin the case discussion. So let's look at these two, right? So we have, so this is Dr. Priya Sharma, who works at a hypothetical diabetes center called the Mumbai Diabetes Center. And she has these two patients whom she was reflecting upon in one of her academic sessions. So both of them were 45-year-old when they were first diagnosed with type 2 diabetes. So you have, on one hand, Mr. Rajiv Mehta, who is a software engineer by profession, and he was started on dapagliflozin with metformin. And then on the other hand, we have Mr. Vikram Patel, who is a high school physics teacher, who was started on metformin alone. And what we're going to see is how their journey pans out over a period of time. Now we have the detailed case in the case review, which we have shared as a file, and it's also there on the website. Now, both of these patients presented with an HbA1c of 7.8% with hypertension, dyslipidemia, and microalbuminuria at the diagnosis. So let's begin right with the first poll question, and we'll take your opinion on the first poll. So just give me a second to launch the poll. Yeah, so you can see the, sorry. Yeah, so you should be able to see the poll on the screen. So the question for you is, in your practice, what factors influence your decision to add an SGLT2 as the initial therapy for a patient with type 2 diabetes? So would you go by presence of a cardiovascular disease? Would you go by presence of a kidney disease or albuminuria? Would you look at the patient's weight and BMI? Of course, there could be multiple answers, but what would be the best answer for you? And would you consider the a family history of diabetes-related complications? So what is your compelling reason for starting an SGLT2 right at the beginning when a patient comes to you with a high HbA1c or with a HbA1c or something like this, like a 7.8 or something? Okay. So while we wait for the audience to give their answers, let's then take Dr. Gagan Priya ma'am's opinion. So, ma'am, this is the first patient, Mr. Rajiv Mehta, and he's a 45-year-old, and he's a primary breadwinner of his family. He mainly has a sedentary lifestyle, works for long hours at a software job, mainly a job which requires a lot of sitting, and we know that sitting is the new smoking. And he has a strong family history of diabetes. He has a father who had undergone dialysis, and he had a grandfather who died with a myocardial infarction. His BMI is 32. His blood pressure is 148/92. His HbA1c when he first presented was 7.5, and his urine albumin creatinine ratio was 45, and his EGFR was 85 when he had first presented. So my question to you, ma'am, is that when you have these patients who come to you for the first time, now one pet peeve which you often have is that patients often, when they first come, they just shove those reports in front of your face without really telling what is the problem they're facing. So when you have a patient like this, this typical profile of patient who would probably be showing this, or would be coming with an mobile phone with their reports, what are the key questions that you often ask when you assess such a patient who comes to you in your OPDs?
Yeah, thank you. I think a very, very important thing that we are here to, treat people. I wouldn't even call them patients, because once we go on that level of, saying he is a patient, he requires patience, there's a disease to treat, I think the connect with the person in front of you doesn't develop too much. So what I normally do in my practice, when the person comes and sits in front of them and they try to put in the reports, I just put them aside. I say, first tell me, what are your concerns?
Right.
So what brings you to my clinic? So what is the primary concern in this particular person? Is it that the diabetes has been diagnosed? What is their level of motivation in a person with diabetes? That's something that I would like to assess the first and foremost, right? Where are they coming from? What brings them suddenly? A person may have had diabetes for 1 year, ignored it, but suddenly decides to come. Because those are some factors which I would pick up upon to then take the conversation forward. What brings them here? What is their level of motivation to change, the level of motivation to adhere to any lifestyle or medication advice? So that, I think, is first and foremost. I would, for this person, ask about how his is there a family history of diabetes? That's coming forth here. Are there any risk factors in the family for diabetes related complications? It could be cardiovascular disease, chronic kidney disease. What was the age of onset in his father and how it progressed? Did he require insulin early on? So those are things I would want to ask. I would also want to inquire about his lifestyle kind of habits.
Yeah.
Particularly, when does he eat? What does he eat? When does he sleep? In addition to, the sitting, even the sleep has a very important role. So those things I would like to inquire. Are there any osmotic symptoms that the person had? Is there any change in weight? Now, weight can be a very tricky thing to, pursue, because the moment
Right.
you start asking, did you gain weight? Sometimes patients become defensive. So I like to ask a more neutral question. Has there been a weight change in the last? Has it increased or decreased or stayed the same? So then they kind of come up with the story. Also, erectile dysfunction is there or not? How is his married life? What about the children? So these are things I would like to assess before I can take the next step and start evaluating the reports.
True, ma'am. And this patient has a, very interestingly, has a father who had diabetes and went
Yeah.
on dialysis. So, we all know family history is very important for these chronic metabolic disorders. Do the complications also run in the family? For example, you had a patient with a father with type 2 diabetes with CKD. Is it more likely that the son with diabetes will also have the same complications?
Yeah. So we've seen it over and over, and we still don't completely understand why some people have a certain set of complications and why some don't. I mean, there
Right.
will be people running with really uncontrolled blood glucose levels and still not having any decline in EGFR, any albuminuria, and some will have terrible neuropathy, some will have chronic kidney disease developing even in pre-diabetes stage. So family history is one of the factors which seems to have a predictive role there. So yes, your alarm bells do go up that there is an inherent tendency to develop CKD. So you want to protect the kidneys. For sure, that should be inquired. I think for all complications, we should be inquiring. It may
Right.
have to do with polymorphisms in some of the RAS pathway molecules, but
Right.
we completely don't understand what drives that risk.
Okay. Yeah, great point, ma'am. So let's move on. If we just ask this as a poll question, ma'am, and you can see amongst the doctors, one of the driving forces why they should consider an SGLT2 right off the bat is presence of a cardiovascular disease. So 48% of the audience has said that, if you have a cardiovascular disease, a pre-existing cardiovascular disease, you would probably choose an SGLT2 over and above, any other thing. Now, this patient doesn't overtly have a cardiovascular disease, right? So in this patient, what would be a compelling reason to put him on an SGLT2? Because the endocrinologist here, she chose to put the patient apart from a metformin on an SGLT2 in her wisdom. And maybe, if see, probably this patient was seen 10 years back when, SGLT2 was still relatively new. What would be your compelling reason in this patient for putting the patient on an SGLT2?
So if I just make a complete diagnosis for this person, we
Yeah,
have obesity of class 2, so his BMI
right,
is 32. It is in stage 2. Edmonton staging is there for obesity, which also takes into account the comorbidities. So there's
right,
already diabetes, hypertension, dyslipidemia, all of those factors are coming in. Then there is type 2 diabetes of newly diagnosed with hypertension, dyslipidemia, and we have to do the kidney staging also. So
yeah,
he has chronic kidney disease stage 2 as per EGFR and A2 category. So this is the net complete diagnosis that I would be, and I would also want to look at the liver status, right? There might be MASLD in the background. There might also be obstructive sleep apnea in the background.
right,
Now, when I'm choosing treatments, first and foremost, I'll decide what target A1C do I want to accomplish in this person. We are
right.
sitting at 7.8. Do I want to go to 7? Do I want to go to 6.5 or maybe even close to 6, right? And uh, I would err on the side of a lower A1C, because what I tell younger people and middle-aged people when they come in the first diagnosis, we have a long race to run. It's not just a sprint, we have to go a marathon further.
Right,
And what
right,
we do today is going to determine how far in the marathon we can actually run.
right.
So I would rather target a tighter A1C. I would look at the level of motivation and try to, nudge the patient towards a tighter target. The next question is, do I want to go with one drug, two drugs? in this scenario, I think 2 drugs makes the best sense, because
Right.
7.8 to closer to 6.5 or below closer to 6, we're going to require 2 drugs. And study after study has actually shown that, you can preserve beta cell, you can prevent complications if you control intensively in the very first years, right? So SGLT2 inhibitors, there are pointers. One, my choice here would be after metformin between a GLP-1 RA and SGLT2 inhibitor.
Right.
Personally, I feel he is a candidate for both.
Right.
Now, the albuminuria does push me towards an SGLT2 inhibitor, but I would also want to discuss a GLP-1 RA at this point of time with this patient. And of course,
Right.
take care of blood pressure, take care of lipids and other things. So albuminuria does, and the family history of chronic kidney disease in the father needing dialysis or towards end-stage renal disease, does push me towards SGLT2 inhibitors.
Okay.
I'm actually surprised at, the poll answer, because
Yeah.
the cardiovascular disease is not that big a concern, particularly here. And
Right.
even for SGLT2 inhibitors, my compelling reasons would be if there is CHF or risk factors,
Right.
or there is CKD. These
Okay.
are the 2 top priorities where I would immediately pick an SGLT2 inhibitor. For CVD, I'll be juggling between GLP-1 RA and SGLT2.
Right. Right.
Because we know MACE risk reduction, the actually atherosclerotic process risk reduction happens with GLP-1 RAs.
Absolutely. Right. So I think it's a marathon, not a sprint. And another take home I'll take, is that CHF and CKD are the stronger compelling reasons to put a patient on a SGLT2 compared to a GLP, which is again a fair decision to make as far as a patient is concerned. And like you said, why not both? Both could be considered as potential treatment. People have raised their hands. What I'll suggest is just put your questions in the chat so that we can take it with that, and we'll allow you to speak at the end so that we can have more kind of proper scheduling of time. Okay, so yes, ma'am.
No,
Yes, yeah. Okay.
That was
So
interesting.
yeah, so we have this then contrast with another patient who is exactly the same, right? Apart from the job, he's a 45-year-old, person who is basically a physics school teacher, has, as you can see, a little bit of limitation of activity because of knee pain, is osteoarthritis. I just saw today a young patient who just came to me because his orthopedic surgeon referred for weight loss because he had knee joint osteoarthritis at a young age, right? So that this also becomes credible reasons to, lose weight. This guy has his mother has diabetes, some neuropathy, but no major complications to speak of. His BMI is again 30. His blood pressure is 145/90. HbA1c is similar. Urine albumin ratio is similar, and the eGFR is also the same. So, man, of course, this patient in hindsight was just started on a metformin, but the guidelines are still, a lot of them are still saying, of course, some of them have changed, but some of them are still saying that, metformin is the first choice of an anti-diabetic drug. Do you agree to that? Do you agree that a metformin in today's era, where you have better drugs available, is still the first choice or the
Uh,
only choice?
Yeah, I think I'll put it like this. Metformin may not be the only first choice. We
Yeah,
do have patients coming with A1C of 6.5 with kidney disease or risk factors or CAD, where I think I jump to a SGLT2 inhibitor straight away
right,
before initiating metformin. There is a good evidence base for metformin, definitely, and it's a time-tested molecule. It's a safe molecule. But in such scenarios, eventually patients need multiple drugs to get glycemic control and also risk factor reduction. So we should not use that stepped care approach, the ABC approach that used to happen when I was doing in my MD. Probably things started to change during your time. We had only glimepiride, metformin. Glimepiride had come in a big way by my time. So glimepiride, metformin, pioglitazone came in and out with concerns, and then we had insulin. So we didn't really have too many choices, and the stepped care approach at that time was reasonable. But we should try and use combination therapies early on.
right,
And while metformin can always remain in the background, it should be supported by other therapies. So
right,
at this point, and if you look at data coming in from trials like Verify, that was one trial with vildagliptin, though it's a different
right,
class of drugs, but it did show that early combinations are safe and effective. And
Right.
most of the outcome trials, even when you talk of, the DAPA trials, Declare to Me and others, you can see that even at these A1Cs, two drug combinations have been used very safely. So this patient also, in my idea, again, the diagnosis is the same. There's obesity and all of those things are there. So I would again prefer two drug combination. Now, the
Right.
question is what in addition to metformin? Where would
Yeah.
you do there? Yeah.
Right. Okay, great. So I think, point well taken. And again, those who have questions, please put it in the chat so that we can take it along with the thing, and then we'll allow you to speak. Okay, so we already discussed these points. Now let's put in the second poll again for, the audience. And this is where kind of hits on the very topic which ma'am talked about, is using, SGLT2 from a perspective of kidney. So let me just run this poll, and while we discuss, this point. Uh, yeah. So we have the question on the screen for you, so you can, try answering this. So for a newly diagnosed patient with type 2 diabetes with microalbuminuria, but no established CVD, which initial treatment approach would we choose? I think, in hindsight, of course, you will choose something very obvious, but again, would like to know the choices of the audience. Metformin alone, metformin SGLT2 with a DPP4, with a GLP. I think that's again a fair question, or other combination therapy. So, ma'am, just to play the devil's advocate, you talked about SGLT2. Uh, just again, from a sake of argument, now you have a lot of evidence generated from GLP as well, right? Now, of course, we were limited with the GLPs that were available then, but now we have better choices also coming in India. So when you have all the choices available, and GLP also showing benefit as far as the microalbuminuria and renal risk reduction is concerned, why then SGLT2 in this scenario would score slightly higher over a GLP? Again, just from an argument's sake.
So if you look at the evidence, definitely there's evidence for GLP-1 RA,
Yeah.
but for SGLT2 inhibitors, there's overwhelming evidence.
Right.
The
Okay.
progression of chronic kidney disease is not just albuminuria reduction. The hard endpoint kidney reduction is to the tune of 35 to somewhere even 39% in some of the studies.
Right.
The
Right.
renal benefits, there are multiple mechanisms with SGLT2 inhibitor which go beyond glucose lowering.
Right.
There is natriuresis, there is restoration of tubuloglomerular feedback, there are hemodynamic changes, the renal erythropoietin production improves, there is improved, the metabolism in the myocardium as well as the kidney parenchyma. So all of those factors actually indicate that SGLT2 automatically becomes the first choice. And you can,
Right.
this also shows in the KDIGO guidelines, the kidney guidelines, that metformin plus SGLT2 is your first choice in such a scenario. GLP-1 RA is the next molecule of my preference, right? So the
Right.
next molecule, when I want to add something onto a SGLT2 inhibitor, then I would go towards GLP-1 RA. But again, 445 and weight being that much, again, this is a trick question, which I will discuss with the patient and let them choose, if they can afford a GLP-1 RA. Are we even discussing that? And
Right.
are they even motivated enough to either take a daily injection or a weekly injection or a daily expensive tablet? But yes, I would first begin with SGLT2. Eventually down the line, I think, say, third and fourth drugs are going to come in.
Right. So again, the undercurrent here, again, we need to, see patients from a real perspective. And again, cost is also something which is very important. I think, that should be part of our discussion, because again, we're looking at long-term therapies. We're looking at, treatments which have to be taken for a long, long time. We don't know whether, the price of the other drugs will be cheaper in the print. But what we do know now, right now, is that SGLT2 inhibitors tend to be a very cost-effective option as well. So I think that's a great point here. 56% of the audience has agreed with what we are discussing, and they would probably consider metformin with an SGLT2 as the first choice, in such a patient from again a renal perspective. Okay, moving on. So let's then look at Rajiv's follow-up, right? So Rajiv was the person who was started on an SGLT2 with metformin. and this patient lost 4 kgs. So this is, on the follow-up of the patient, he lost 4 kgs. His blood pressure is about 138 by 85. If you remember, he was hypertensive, and he did have a little bit of blood pressure reduction with the SGLT2 alone. His HbA1c came down. So this is probably the first follow-up. His HbA1c came down from 7.8 to 7.1. So there is a 0.6% reduction. Of course, if we go down the line, it might improve. And his urine albumin creatinine ratio is also coming down a bit. He did, of course, have some symptoms of increased urination, which have been stabilized. No genital infection to speak of, no episodes of dehydration. Of course, these drugs do not produce hypoglycemia, so there was no hypoglycemia episode. Ma'am, little underwhelming in terms of the HbA1c reduction. We expected a little bit more, maybe compliance, newly diagnosed patient, motivation from other points perspective. But he did lose a good amount of weight, a 4 kg weight loss. So how is your experience with the first follow-up of these patients, when you see them for the first time? Do they lose weight to the tune which, trials have shown, or is there a more weight loss in Indian patients compared to what you see in clinical trials? So how's your experience in when you see this patient on the first follow-up?
So in most patients, I think the average weight reduction we see is about that 2 to 3 or maximum 4 kgs. We do
Yeah.
see that kind.
Yeah.
There will be a small subgroup of patients who actually lose quite a bit of weight, and they keep losing weight. Like today also, I had this gentleman, he started at 70, went to 66, 64, and today I was worried at 60, and I had to just, okay, let's hold it. Let me put you on a high protein diet and call you back. But that's a very, very small segment of people wherein that happens. By and large, this kind of weight reduction, part of it is also that volume retention. So it's also a kind of, the excess
Like a
water that's being lost.
diuretic effect.
And to some, diuretic effect or whatever we want to call it. And then it's more about the patient. This patient, I think, there might be issues with lifestyle that because the glycemic response is not really what I would have anticipated.
Right. Not at the first follow-up, at least, right. So I think, yes. So again, compliance and the other things, often kind of also weigh in. And then Vikram, who is the other guy who was just on metformin and his first follow-up, he also did lose some weight, right? 2 kgs again, metformin also helps, but of course, he had his own lifestyle things and not much of blood pressure reduction. Probably we need an antihypertensive as well. And, the HbA1c reduction was seen and, to some extent, again, not great, but what you'll probably expect with metformin alone. Slight change in urine albumin creatinine ratio, again, too early to really speak right now. So overall, slight improvement in energy levels, some GI discomfort with metformin, transiently. So these are typical things. Inconsistent exercise, again, because of knee pain, which he continues to be a problem for him. And there are some modest dietary changes, which he did. So ma'am, you have these patients, both of them, they come to you for diabetes management, but they'll often fight with you when you start an antihypertensive. BP to mera theek hai. I think that's or common excuse, my patient said, I just walked in, I just came walking up and then that's why my blood pressure is high. So they're a little defensive about starting an antihypertensive medication, probably will this gentleman also. What's your experience in that regard, saying again, a real sense of,
So again, I think we have to first set clear goals in our mind about where the patient should be, what should be his target. So goal setting is something we need to do right in the beginning, that look, this should be your A1C. This is where the blood pressure should be. Unfortunately, the recent JNC guidelines added more confusion than clarity. But if we stick to our diabetes guidelines and look at the Kidney Association guidelines, they are clear that a tighter target in younger individuals who still have not developed all of those comorbidities, that's actually what will help with albuminuria or down the line, even with cardiovascular risk. So I would rather, yes, all of those defense mechanisms happen. We usually tell, okay, 10 minute baitho, let's check your blood pressure again, sit down, calm down. And usually we show them it again. Some people, we tell them to do home monitoring or ambulatory blood pressure monitoring. And when those readings come back again, that's, a way to show them that, this treating this will help. Evidence, discussion of evidence is important. So one part of, the entire motivation, if you look at motivational interviewing, one aspect of it is sharing information, that has to be imparted, that look, diabetes and these things go hand in hand. They are all two, I usually say, though villain, they are moving together. So we need to target both of them. We can't, attack one and expect the other not to overpower. So blood pressure control, and these are your targets. This is where we want to be with there also. And also discuss organ protection. That look, choices I make in diabetes medications, choices you make in lifestyle also going to give you organ protection. But this is what the evidence says, that we need to target blood pressure, we need to target lipids. If there's smoking in the background, that needs to be discontinued. So all of those things, it's not just about a glucocentric approach, it's about the 4 pillars of management: blood pressure, glucose, weight, and also the risk reduction, lipids and the risk reduction. So all of those pillars need to be taken together.
Yeah, I think a great point. Set the targets right at the beginning, right? So I think, discuss right at the first instance that, this is what we are looking at in terms of the multi-pronged risk reduction, rather than just, again, we are also often guilty of just, putting the patient saying that, okay, we'll get your HbA1c fine, but, then probably forget about your blood pressure. So I think that often happens. I think this is a point we already discussed. So let's run the third poll again for the audience. And meanwhile, there is some question also, we'll just take that. Just give me a second. Yeah, so you can see the poll. I'll just flash it on the screen for you. And just one second. Yeah, so at the end of 3 months, again, we discussed a little too early, but we still have certain residual issues with Vikram, right? With Rajiv, it was pretty okay. So at Vikram, we have urine albumin creat ratio being high, and this is exactly what we discussed with ma'am also. So, the UACR, of course, the blood pressure also, both of them are still not in the target which should reach. Should you continue the same treatment? Would you add an SGLT2 now? Would you add an ACE inhibitor ARB? Would you add another class of antidiabetic, maybe a GLP, or would you focus on lifestyle measure more? Ma'am, what's your take? Would you, at this point, I mean, we didn't start Vikram on an SGLT2 then. At this point, would you start him on an SGLT2? Would you like to add an ACE or ARB? I think it's a difficult choice. Maybe both, you'll say. But
I would say both, actually.
But maybe, if you had to choose one, again, of the two, maybe, 10 years back, SGLT2 were expensive. So would you consider ACE ARB or an SGLT2? What gives more kind of value for money?
I think both are important pillars. I would possibly shift the patient from a metformin to an FDC of SGLT2 plus metformin, and then also add an ARB there. But I think both are required.
So it's a great message. I think, what we now need to see is that stepwise approach is fast disappearing. You tend to have more of, use all the things you have in your, in your armamentarium to help the patient. So I think, why not both? And I think that's a very fair point. Okay. Of course, the option, are not aligned in that way, but fine. A lot of audience, 58% would like to add an SGLT2 now. And then a fair number also would consider an ACE inhibitor ARB. I think both of which in combined is a good choice to really see. Okay, so I think again, it's an important message through is that the urine albumin creat ratio is also important. So ma'am, how do you see the trajectory of that really play off, over a period of time? So we know that SGLT2 inhibitors also reduces urine albumin creat ratio. Of course, it protects the kidney, but there is a marker, actual live biomarker, which you can trace. Same with the ACE and ARBs. How does it really play out? Again, there's often not a linear fall, but there is some fall over a period of time. So how do you really trace, and how frequently do you ask for the urine albumin creat ratio?
So I think I usually do what was done in this case, that the first UACR I would do after about 3 months, assess, and if it's not really falling to the tune that I wanted to, I'll assess for factors why it did not happen. Maybe the ARB was not in place, maybe there are compliance issues or adherence issues. So those things need to be assessed. Another thing, rule out a UTI if it's coming false, or not. So that has to be looked at. There is often a decline seen at 3 months. It may not normalize or may not really have a very significant fall, but a decline does happen. At the same time, also, when you're tracing the EGFR, don't worry about a small reduction in EGFR in the first month.
Right.
It will usually come back and hold itself later on.
Yeah.
So this is there. And in regard to what we were discussing earlier, I think as clinicians, we have to understand inertia happens at two levels. And what I tell patients in my OPD is कि हम खड़े हैं सामने से truck आ रहा है and we are not moving, then accidents happen in that scenario, right? So inertia happens at patient's level. It is a
Right.
given because the society is full of myths, misconceptions. They've had some buddies, they've heard this, heard that. They don't really understand how these molecules work or how new medications in diabetes actually help. And
Right.
there is a whole plethora of misinformation and misguidance that's going around, which they've been hearing. So that inertia is there, but clinical inertia at the level of the clinician is something we have to overcome. It's the onus is on us that first we understand why this is required, and then we can convince the patient that it's good for them.
Right. Great. So I think we have this question, regarding EGFR from Dr. Biswa from Kolkata. And he's saying that, is there a difference when you are, calculating EGFR when your patient is on a DEPA or an EMPA? Do these drugs impact your EGFR calculation? And secondly, I think I'll add a caveat to this. What formula do you use in your practice? And like you said, you talked a bit about, there might be a transient reduction of EGFR in the first follow-up in some of these patients. Why does it happen, and at what level do you are alarmed, and you kind of say that there's something wrong?
So what we routinely use for most of our patients is the CKD API calculator. It works by and large well, but it's only in the extremes of age and elderly, wherein you might have. There are cystatin, people have actually also looked, if you look at research publications, cystatin is another marker which can be added to the EGFR calculation to improve its accuracy. But by and large, we don't do it. I don't think cystatin is freely available as a measure anywhere. So CKD API can be used. A slight decline in EGFR does happen because early on there is a glomerular hyperfiltration in people with diabetes, and this drug is acting by reducing glomerular hyperfiltration, the same way that ARB is doing it.
Right.
So in both ARBs and in this, you can see that reverse tick sign. It may or may not happen in all patients, but you can see it. Slight decline and then an actual improvement and sustenance of the EGFR. So I would not worry unless and until the EGFR decline is more than 15 to 20%.
Right.
When ARBs came, ACE inhibitors, ARBs came into the picture, nephrologists also used to try and convince us that this is what you have to do. So very rarely there might be an AKI, acute kidney injury. In fact, if you look at trials of dapagliflozin or empagliflozin, AKI actually risk was less in
reduce over a period of time. Yeah. So great. I think so. Great point. I think we shouldn't be alarmed. I think, and again, something reassuring to a patient. And we, I saw nephrologists often draw this reverse tick sign to right at the back. So like again, the goal setting. Before the patient realizes this, right at the beginning, when they add an SGLT2 or a ACRB from their side, they often show that there might be a transient drop, and then there is an improvement over a long time. So again, look at the big picture, the long picture, over a period of time. So we again had then follow-up of over a longer period of time with both Rajiv and Vikram. And though Vikram was not unfortunately added on SGLT2, even though there was some, and a lot of the audience also agreed that probably should have been the case. Over a period of maybe, let's say 6 months or a year or a longer time frame, Rajiv lost further weight, 88 kg. Again, may not be just a effect of SGLT2, would be, of course, lifestyle improvement also. And maybe, some of these patients are motivated with that initial weight loss to lose more weight, whereas Vikram did lose some weight, but just a 5 kg weight loss. Blood pressure, Rajiv's blood pressure is lower. Vikram, is still slightly in that 130s range, 135 range. HbA1c, again, as expected, Rajiv has a better HbA1c reduction. Vikram has also now reached his reasonable target again, but like ma'am said, maybe the target should be lower for a young patient like this. EGFRs are also somewhere to match, and the urine albumin creatinine ratio now for Rajiv has started to reduce significantly, whereas Vikram is thereabout, probably slight up also, increase of the EGFR as well. So this is the picture. Ma'am, your take on this, and this is the sort of a longer time frame in terms of the follow-up. So what do you read out of this?
So I think when I'm comparing the two, one, I can see Rajiv is losing more weight than I can attribute to SGLT2 inhibitor. And like you said, there might be a better motivation. He lost some initial weight, so he is more motivated. Plus, he has seen CKD in the family. That might have been in the background. The motivation change is immediate. So overall, a lot of the benefits I will also attribute to possibly better lifestyle changes in Rajiv than Vikram. But also, yes, SGLT2 inhibitor is playing a role because UACR has definitely all normalized in his case. Now, if I just stop the comparison and only look at Vikram alone without looking at Rajiv, I am still concerned about what we are seeing. Like superficially, it might be an okay scenario at 1 year. He's lost some weight. His A1C is under 7. But for somebody who's now possibly 46 years, if I'm not wrong, these values would still bother me. I would still want to go lower. I would still want him to lose more weight. And the UACR would still, kind of prick me in the background. And he needs intensification of treatment. Even if intensive treatment was not started earlier, at least now we need to do that.
Absolutely. So moving away from the glucose-centric approach, right? Because if you see from a glucose-centric lens, patient is okay. But if you see it from a more comprehensive lens, you are still having some residual risk, right? You very rightly said. Again, we'll take a poll question here. And we have a question as well from the audience. We'll just take that as well. Just give me 1 second. Yeah. So the fourth poll question, when a patient with type 2 diabetes shows a slight worsening of albuminuria or a persistent high, albumin, urine albumin creatinine ratio, despite good glycemic control, is exactly what we saw. What is your next step again? So similar issue to what we had earlier. Would you add an SGLT to a GLP-ACE inhibitor therapy or refer to a nephrologist, which of course it's, probably not. What about, again, playing the devil's advocate? How about Finrenone? How about an MR antagonist? Because again, that's also coming big in terms of, its use and again, its use case. Now, this patient, let's say he's on an ACE-ARB, his blood pressure is okay, and he's on a metformin. Would you then again add a Finrenone? Again, cost apart. Would you add a Finrenone or would you add an SGLT2? What you would say both, but if you again had to choose one, which one?
I would choose SGLT2 over Finrenone. I would reserve that drug as the next in line. In case after SGLT2 inhibitor also we are still seeing albuminuria, then yes, we can add that. SGLT2 inhibitor by and large has a more stronger evidence base, though yes, there are no head-on comparisons, but it has a stronger evidence base.
Okay, great.
So
great point.
Numbers needed to numbers needed to treat, I think SGLT2 inhibitors are much better.
Scores over it. So point well taken. And, again, Finrenone should be the next step, but not, maybe SGLT2 would be, maybe both, but, maybe SGLT2 becomes a better choice at this point of time. Also, despite the fact that he's having a reasonably okay glycemic control, a good rather glycemic control. Okay, so I think that's, again, what most of the audience also are agreeing to. 77%, again, the numbers are growing. Numbers needed to convince doctors is coming down. So going up. So so I think Jan has said, okay, so she has a few questions. I'll just go through a couple of them. So I think these are great questions. I think, Jan has raised some very valid points, especially when a patient is started on SGLT2. So what are the things we know as advice that you give to a patient when you start them on an SGLT2, particularly from a point of view of risk of euglycemic ketosis and from a point of view of the genital urinary tract infection and the UTI, and she's also talking about would you give some sick day rules to patient and the other things. We'll discuss about fatty liver, Jan, in we have a dedicated session for that later, but would you and in the same question, Dr. Sanjeev has also asked a very interesting question. Would you check for ketones at all? When do you check for ketones? If because these are genuine concerns which patients and doctors have. So yeah, and great questions.
Yeah, I think they're wonderful questions, and very, very important to actually look at these questions and make sure we address these before patients land into trouble. So one general guidance that when I'm starting SGLT2 inhibitors, I often tell, if the blood glucose is very, very high, let's say somebody's come with a fasting of 200, A1C of 11, I usually hold back the SGLT2 inhibitor first of all, because I know too much glucosuria will happen, osmotic symptoms will happen, and usually that scares the patient.
Right.
I usually control and then add them at a slightly later date. I've even used insulin, and insulin, of course, is recommended in those scenarios first,
Right.
and then switch them back. But for regular patients who are not having these osmotic symptoms or really catabolic, there I would first thing tell them to increase their hydration. That
Right.
you are going to expect a slight increase in urine output. Don't worry that the symptom of diabetes has worsened, because sometimes people feel ye to diabetes ka lakshan hai, now it's suddenly increasing. So
Right.
you can hydration, I think, is something very, very important to highlight, and the other is genital hygiene. So that is another factor that we need to emphasize when we are starting it. As far as the fear of UTI is concerned, I don't look for risk factors of UTI. Did this patient have an active urinary tract infection in the recent times? Not in the old past, fine. Maybe a pyelonephritis in the history, a complicated UTI in the history, or in elderly people, if they have BPH and still having symptoms of lower urinary tract, I would maybe possibly treat those first and then add an SGLT2 inhibitor.
Yeah.
As far as metabolic acidosis risk is concerned, the risk is there in two kinds of scenarios. One, where you have used it in a patient with significant insulinopenia and not given the needed insulin.
Right.
Those are the scenarios where euglycemic decay can actually happen. And even I have published 2 case reports of euglycemic decay in such a scenario, where a patient was possibly a LADA or and this got added, the insulin dose came down, and acidosis happened. The other scenario is if these patients of type 2 also become acutely ill. Right. So there is a severe infection. They're undergoing a very major surgery. Mild, I think the moderate degree procedures, we don't really worry about stopping SGLT2 inhibitors, but the ones that require hospitalization, long anesthesia periods, yes, you would want to stop the SGLT2 inhibitor for at least 3 days prior and initiate only once you are assured of the hemodynamic status and the kidney status and hydration is good, oral intake or RT feeds have begun. So that usually takes care of the DKA risk. The only message is do not use it as a substitute for insulin. Because when you're doing that, a patient is having catabolic features, actually needs insulin, you may be able to, have a slight control of blood glucose with the SGLT2. They will come down because glucosuria is going to happen. But that's when you push patients into a decay. So that message needs to be driven. What about sick day instructions? I think again, hydration is the golden rule. And we don't really need to check urine ketones unless the patient is acutely ill. Right. So normally urine ketones, I don't think any guideline says that, or we do in practicality. Only acutely ill patients do check urine ketones. If you have blood ketones, you may. But yes, when a patient is acutely ill, you need a higher index of suspicion of DKA, and DKA may occur at relatively low or even normal blood glucose values. So if you're clinically thinking, there's dehydration, there's unexplained acidosis, then do look for urine ketones, do look at the ABG, and then assess the patient.
Right. So again, sometimes urine ketones also, because they are on SGLT2, they get masked. So I think, again, when there's a strong suspicion, again, probably, look at the, the VBG, the venous blood glucose, that because, the high anion gap there could point towards a potential euglycemic ketosis. Sometimes, often goes unnoticed also. We had patient post cardiothoracic surgery being referred to us with unexplained acidosis, and they found to have glycemic ketosis because again, high risk patients, somebody put them on SGLT2 and not well insulinized. So again, that's the message. I think this is where a good clinician really comes. Because you have that strong eye of suspicion of where not to give an SGLT2 also, because that's again equally important, right? Again, down the line, you continue to see the benefits with Rajiv compared to vis-a-vis Vikram. Vikram has slightly gone up again with his HbA1c, which is again something you notice in patients just on metformin. And this is what, if you say the verified trial also showed that, there are patients who worsen over a period of time, despite being on metformin. I think that's interesting area. Again, urine albumin creatinine ratio, Rajiv continues to have the benefit and Vikram continues to gain a little bit there. And somebody did a fundus also, which you should have done, which they did. And then, now you have Vikram has an evidence of early background diabetic retinopathy also to speak of, whereas Rajiv, probably not because of SGLT, but Rajiv is fine from that point of view. So, you have all these issues now. Now you're probably seeing Vikram from a different perspective. You are seeing Vikram, though good HbA1c, you're seeing with a significant eye of concern, maybe you should have probably on hindsight acted earlier. So I think this is where you see, ma'am, again, I think now it's of course high time to put Vikram on an SGLT2. We should have done it in the earlier follow-up also, but some reason it didn't happen. But what are the things at this point you're concerned about with Vikram? Rajiv is fine.
Yeah, so I think Vikram, again, I'm not happy with the glycemic control. I
Right.
think we had set the wrong target for him, and
Right,
we are
right.
letting him stay at that under 7 target. But the GFR seems to be declining. There is albuminuria seems to be increasing, and of course, diabetic retinopathy. Overall, I would also like to know what was the weight in both the patients, because it seems Rajiv is also the more motivated person here. Right. I don't just attribute everything to a drug, but also the level of motivation and
also.
the adherence to every lifestyle measure, plus, of course, medications as well. But definitely, Vikram now needs a second agent, preferably an SGLT2 inhibitor.
Right. So we have a couple of quick questions from the audience, and Dr. Ramaswamy has asked about Findenon, I think, which we discussed already. So I think, we'll leave it to that. And we have Dr. Ramaswamy a session with a nephrologist also down the line. So we'll discuss that in more detail. Then we have, Dr. Sanjeev asking, if you have an actual UTI or GTI, would you stop the drug? Again, I'll take the next question also in the same light. Somebody, guest audience has asked, EGFR of less than 20 is a contraindication to SGLT2. Would you initiate, or would you have a drop in EGFR and stop SGLT2? So primarily, what are the situations where you stop an SGLT2 apart from, a frank diabetic ketoacidosis, or the other things you already talked about, surgery, major surgery? When do you consider stopping, in a routine practice, when you consider stopping SGLT2?
Yeah, so when I would want to stop is if there is recurrent troublesome UTI or a complicated UTI.
Right.
That is where I would stop. As far as the EGFR category is concerned, do not initiate below 20. You won't get much benefit there. But if the patient is already on SGLT2 inhibitor, you can continue it safely till the patient goes on renal replacement therapy in either the dialysis or transplant. And now we have evidence post-transplant also that it helps. So less than 20, initiation, no, but continuation, if hemodynamically stable, you can continue. You don't even have to adjust the dose. As far as patient developing UTI, I think that there are two questions inside this. One is genital mycotic infections. I would not stop at that. I would possibly give them a course of antifungals, topical if required oral, and improve the hygiene and call them back. If the genital mycotic infection is becoming really troublesome, not keeps relapsing, then maybe I would think about, whether or not to discontinue, or whether to continue, give a longer course of antifungals in that case. For UTIs, again, cystitis or lower urinary tract infections, I think we can safely continue it, or maybe put a temporary hold and then restart after treating the UTI. Upper tract UTIs or recurrent UTI or UTI with sepsis that has come in, then I just put them on hold. And I've had patients even from close family and friends who've actually had pyelonephritis, possibly caused by some other reason, but I've not had the courage of putting them back on SGLT2 inhibitor.
Right. Okay, great points. Again, if you see Vikram, so I think the timeline says 3 years, but maybe look at a longer time frame, take it with a pinch of salt. Looking at a longer time frame, now you're actually seeing the things play out, right? So he's having a left ventricular hypertrophy on an echocardiography. His urine albumin creatinine ratio continues to go up. This is when Dr. Sharma also woke up and said, okay, he badly needs an SGLT2. So this is when he was then started on SGLT2, where you clearly see now, and the idea really was to show you the spectrum of how the patient goes. So you have on one hand, of course, Rajiv, we can always, it could always be that he was a slightly more motivated guy. But I think, again, maybe the initial treatment benefits also motivated him further. So that could also play. But then now you can see at 3 years, you have Vikram, who is still struggling with these other issues. And if you continue to go, maybe would go on to develop more complications down the line. Whereas Rajiv is doing far better in terms of all the things, again, could be attributed to the additional weight loss and motivation also. So, ma'am, again, looking at the big picture here, you clearly see there is good evidence to show that there is some, early benefits in 3-year, 4-year, 5-year timeline also with an SGLT2. Do you see this play out in real life, ma'am? That this, again, these are both derived from real cases, but still hypothetical in a way. Do you see, this delay in intervention, delay in adding SGLT2 really play out in real life situations also?
Definitely. I think that is seen in clinical scenarios, real life clinical cases also, wherein, I mean, when I started practice, DPP4 inhibitors had just come into the market. And I was one of the early enthusiasts. So I have patients who walked into my clinic even after 10 years saying, you put me on this plus metformin, and their A1Cs were below 6.5. The risk factors were not there. The same happened with SGLT2 inhibitors. Even after a decade, I'm seeing those patients. We saw you 3 years ago and still we are doing, and they're actually doing well, right? So early intervention is the key. Hit early, hit hard, and don't be worried about safety concerns, because earlier time, like I said, there was glimepiride, there was insulin, these, and even Dianel we were using. So those molecules had limitations, right? What I like to describe it as, efficacy with efficacy barriers. So they were effective, but there were real barriers of weight gain and hypoglycemia, probably hypoglycemia, the bigger barrier. Now we have molecules which don't have that barrier.
Right.
Earlier molecules did not offer organ protection. These molecules offer organ protection. So we should not hold back these, therapies right in the beginning, thinking baad mein use kar lenge. Of course, we have to use them later also, but if you start early, you are going to get longer benefits. And it just doesn't have to be glucose centric. Steno-2 trial clearly showed that a multiple risk factor reduction model will work better in the long run. So what the Steno-2, it added 8 years of life to a person's journey. And what I like to often call it is, add life to years, years to life, and also life to years, because those 8 years were of less complication risk. The 8 years that got added wasn't fighting disease, was a healthy 8 years that got added. So
Absolutely.
both years to life and life to years you're getting.
Right. I think, and you can clearly see that play out with Rajiv also here. So I think, there are a lot of questions. We'll just quickly go through the slides, and so that we'll take the questions from the audience. That's the whole purpose. You can see the journey of both Vikram in terms of the EGFR also, and then over a period of time. And then you look at the cardiovascular risk also, over a period of time. And then, he had a CT calcium score. Again, clearly there are issues with Vikram. Maybe there could be a certain underlying issue. Maybe it's chance event that, he was not on SGLT2 and he was the one who is developing all these issues. But again, you see his CT calcium score is also 120, maybe then becomes a candidate for statins as well. Whereas, Rajiv, everything is doing kind of great. Again, exaggerated picture like Hindi movies, we have one hero and the other one struggling, but that is what ultimately happened, right? So again, 5 years down the line, Rajiv, no evidence of retinopathy, no neuropathy, no nephropathy. He's doing great. Whereas Vikram, whom eventually we did put him on an SGLT2, he has early diabetic retinopathy, no neuropathy though, but continues to have albuminuria. And again, then becomes a candidate for additional therapies like yofindanon and intensification of the ACE inhibitor ARB as well. So, ma'am, again, let's quickly go through the slides. Okay. and then we'll take the questions and thing. And this is what Dr. Sharma, who was the treating endocrinologist for both these patients, she opined in a way that, looking at the journey of these two patients, early intervention, very, very rightly you said, I think you picked up the point, that's the key message here. Again, beyond glycemic control, you had these benefits. And again, like you very rightly said, multi-centric, multi-pronged approach. Personalized risk assessment was important. Again, both these patients had those reasons to put an SGLT2, but there could be patients where you don't require them. So again, that could be thing. And again, cost benefit consideration also now, of course, less of a question now with SGLT2 being much cheaper and easily accessible and available. So these are the points. Ma'am, quick take. There are a lot of questions from the audience. And a lot of these questions, I'll club them together. A lot of them point towards GLP. So Dr. Abhichandani is a very senior, endocrinologist from, Ahmedabad, from my city, a great friend. He says that, why not GLP? He also says that GLP does benefit in these patients, will have weight loss. And of course, one more benefit is that GLP can be given across the spectrum of the CKD. Can be given even with the lower EGFR. And Jan has said that, diabetes with high USER and obesity of BMI more than 30, which would you consider SGLT2 again versus GLP? Both you said right at the beginning. But again, thinking from, again, a perspective of GLP, now these drugs are available in India. Where does GLP really stand? And what are your patients where you would have probably considered GLP in preference to SGLT2? You said this earlier, but let's reiterate this fact again. Which patient, Rajiv, Vikram, or maybe the third, Sunil, what Sunil would be, to consider a GLP?
Yeah. So I think with regard to a patient who is having persistent albuminuria despite SGLT2 inhibitor, then yes, of course, when I'm needing glycemic intensification, GLP-RA will automatically come into choice. If weight reduction is my priority, again, GLP-1RA will come into choice. And while in Rajiv, weight reduction started to happen, probably he intensified his lifestyle. In Vikram, it was not happening, right? So I would first maybe add a SGLT2 inhibitor, start discussing GLP-1RA, and definitely consider adding that. Now, between GLP-1RA and SGLT2 inhibitor, which way I would go would, I think if there is, the obesity is causing a lot of other problems. There's MSLD, sleep apnea, there's exercise difficulty, like in this, in Vikram, there was that issue. I would definitely err towards a GLP-1RA. I think the GLP-1RA conversation I am starting now in pre-diabetes stage, now that it's approved and available.
Right.
Not GLP-1RA, but the dual cretin is available.
Right.
So that conversation is beginning much earlier in my clinic. And I've, even in a month's time, I think I've seen some patients really do very well in that therapy. But I think rather than pitching one drug against the other, I would say we have both the molecules, right?
Why not use both?
It's not really.
Yeah, but ma'am, interestingly, if you see Vikram himself, he had LVH, but if you see his CT calcium score was 120, he probably has atherosclerotic kind of pictures.
So in that case, that's
maybe and he already had knee joint osteoarthritis to speak of. And then, maybe at later date, we added an SGLT2. Would GLP would have been a better choice, or maybe would have been an equally good choice, or maybe an additional drug which you could have considered?
In his case, I think the weight loss was the bigger issue, and that
right, and which absolutely,
the HbA1c would have come down, and the whole gamut of things would have reversed, which actually progressed. So GLP-1RA definitely will be my first preference to him, but if he was resistant to the idea of a SGLT2 inhibitor, I don't think GLP-1RA would have been a point of discussion. Like in this case, I think he resisted even the initiation of a second simple drug.
Right.
So GLP-1RA is a whole different ball game.
Right. Okay, absolutely. So Dr. Gaurav Majumdar has asked a very interesting question. What about, we're not talking about it. What about sulfonylureas? Why not SU? I mean, this is because in real practice, probably, 10 years back, both Vikram and Rajiv might have been on SU, to speak of. In reality, where does really SU come into picture? Again, in a more global sense in terms of real life practice.
So I would rather put it as a third or fourth line drug. In
Right.
the question that he's asked, he's particularly talked of metformin intolerance. So
Right.
I would rather go with SGLT2 plus TPP4 inhibitor or SGLT2 plus GLP-1RA. And metformin intolerance doesn't mean the patient will not tolerate GLP-1RA. I actually have a few patients who never tolerated metformin, and now they are taking GLP-1RA. So that does work. And then down the line, I would consider a sulfonylurea and start at lower doses. So
Right.
it'll be a molecule that's going to come
Down
eventually.
the line.
There's nothing,
Down.
sulfonylureas are not out of the picture. They're going to
Right.
be used in a large majority of patients, but we can keep them as, later.
A
Down
reserve
the line.
draft later. Yeah. Right. Okay. And I think we already answered about the EGFR less than 20, which somebody has asked. I think, we already said that you would not initiate it, but if you have a patient already on an SGLT2 and there is a drop of EGFR over a period of time, you probably continue SGLT2 as the guidelines also, and both KDIGO and the ADA guidelines also are very clear and about it. So if your EGFR is 20, you will probably not initiate it, but you will not discontinue it if you're going on that course. And Sanjeev talked about uric acid. That's an additional benefit with SGLT2. Have you seen this benefit in your practice? Yeah,
Lot of times.
a lot of times. Yeah,
So there's very
absolutely.
significant reduction in some patients.
Yes,
Sometimes
absolutely.
even 3 or 4 uric acid comes in. Yeah.
Right. And Mahesh V has asked a very interesting question, comparison between the SGLT2. So it's like making a choice between your children, which is very difficult.
Yeah.
Any points there?
I think we're just basically talking of two molecules, EMPA and DAPA here.
Right.
And both are equally. There's a class effect as far as kidney benefits are concerned. I think the heart benefits are also similar. So it's just that the trials had different patient population, different outcomes as primary outcomes and secondary outcomes. But by and large, they both work fine. We are not talking of any other SGLT2 inhibitor. They are
Primarily
by
these
and
two.
large out of the game. Though canagliflozin wasn't that bad. It was a good molecule. It was fairly decent, good molecule.
Right. Probably even, I think the pharmacoeconomics also working there. So Mahesh has asked about N-acetylcysteine. I think Mahesh, leave this question for a nephrologist. We'll put them on the spot there. And Dr. R.D. Anand has said that you have a patient with HbA1c of 12, clearly refuses insulin. Would SU be a choice, apart from the other things?
Yeah, definitely in that scenario. But at HbA1c, yeah, we do have even 13 walking in. Completely, definitely counsel them about short-term insulin. And I mean, you may not still be convinced that this is type 2 diabetes, but a short-term insulin course will make a difference. It'll preserve the pancreatic function for a longer period of time. But if they don't agree to it, then add a sulfonylurea. So, but the message here is that a lot of patients, young patients suddenly come up with bad lifestyle, sudden high sugars, they get controlled, and then you should not be continuing the SU.
Right.
So after about 4 to 6 weeks, once we've hit the target, I switch them over to metformin plus DPP4 or metformin plus, DPP4 plus SGLT2 or GLP-1RA, that combination.
Absolutely. I think it's a great point because the glucotoxicity falls and suddenly start developing hypoglycemia. So again, that's something which you have to be careful. That 12 HbA1c will not take time to bring down to a level and then they start very rapidly. So correct, right? So Mahesh has asked about imiglimid. I think that's a separate topic, not for our today's discussion. It's a separate topic altogether. And Sanjeev has asked about SGLT2 and DPP4 combination. Ma'am, where do you see SGLT2 DPP4 combination in today's? Because these are now fairly easily available, all permutations and combinations. So I think you talked about, a patient early on. So it's a great choice. And I think we then take the last question from Vishal, who says that can SGLT2 inhibitors reduce the need for loop diuretics in heart failure? Again, we have a session with cardiologists, but ma'am, what's your opinion on?
Definitely. And in fact, when patients are on high dose loop diuretics and you're adding an SGLT2 inhibitor, it'll be a good idea to at least reduce the dose by half of the loop diuretic because they work very well. So
I think we have a lot of other questions. I think we'll leave it to the cardiology session next, because we have, so we'll just quick take home message from you for the entire discussion. And I think we looked at the journey of, the two patients, one of them both very similar at the beginning, but at the end, you could clearly see the contrast between their journeys. Your take and your opinion.
So I think the most important carry home message is that we should avoid clinical inertia at our level. Whatever the patient is coming, they're coming with a story. And sometimes those stories are mired by certain experiences or lack of knowledge. So we should try and impart that knowledge and first make sure we set realistic goals, communicate those goals, and then believe that hitting early, hitting hard is actually be good for in the long run. So it's a long race, a marathon, not a sprint. I think that
Marathon, not a sprint. I think that's the take-home message. Marathon, not a sprint. I think that's the perspective we should look at. I think we're already crossed the time. Any word from Dr. Sameer? Dr. Sameer, anything you would like to add?
Yeah, I think good evening and my compliments to Dr. Gagan, because the way the cases were kind of evaluated, and the way a narrow monitoring was done with respect to the early use of dapagliflozin versus the delayed use, I think that made the difference. The crux I felt was that earlier we start with an agent which initially, having been approved for type 2 diabetes, but later having approvals in heart failure as well as CKD, we have already gone from a glucocentric approach to a organ protection approach. So early in the disease, we start an agent like an SGLT2, dapagliflozin. I think we should extend the benefit to our patients, and they really, kind of benefit a lot from this class of agents. So I think it was a great review of a real life case, and compliments to Dr. Om and Dr. Gagan for a very interactive webinar.
I think we can take maybe a question, because we have promised the audience to, so if you have a question which you want to kind of speak out or discuss with Dr. Gagan Priya, please raise your hand and we'll just do an allowed to talk. We have that option on webinar. And then meanwhile, ma'am, thank you so much for being a part of this, ma'am. The first session, I think it went beautifully. Thank you so much. It was fascinating discussing with you, and your insights and your takes and your very clear judgment, clear thinking. I think that really is wonderful. So thank you so much, and thank you, ma'am, and thank you to Zydus for backing this. Again, complete editorial freedom to us. I think that's a great initiative. Thank you, and thank you to the audience for joining. We have so many people on the webinar on a working day. I think that's really good, really fantastic. So I think thank you all, and we are having the next session next week, same time, same day, where we'll have the cardiologist and we'll discuss a case of a journey of a patient with heart failure and diabetes. So that's, again, you can reserve your, there are a lot of cardiology related questions. We'll reserve that for the cardiologist next time. Thank you, ma'am, for being part of this once again. And thank you, everyone, and good night.
Yeah, thank you.
Good
Good
night.
night, everybody.
Thank you. Thank you,
Thanks.
Dr. Sameer, and thank you, Mehul.
Thank you so much, sir. I think
Yeah,
very
thank
insightful, very informative.
Thank you. Thank you. And thank you to the audience, and we'll sign off. Thank you so much. Good night. Bye.